So what do we need to do? Well, we need to, in some sense, create a new economic and social framework for building, for making a difference. And one of the things that people say about the big society is, well, nobody's got the time, nobody wants to do it. How on earth could we? And yet there's very real evidence that actually there's massive, massive demand to make a difference to our localities in some of our most disadvantaged areas. From some of the research we did with Unlimited, there's something like approaching 250,000 people who want to become social entrepreneurs. And what a social entrepreneur is somebody who wants to make a difference about a social problem in their area and in their locality, and wants to create the economic conditions that allow them to do that. And that will be part of our Any Willing Provider discussion shortly, I'm sure. But only 1% of those people get any money or support to make the difference they want to do. And one of the questions that I'm interested in is, does Any Willing Provider mean private sector capture of the NHS? Does it mean big monopoly providers coming in and essentially specialising the tariff, capturing the tariff in, for instance, depression, but not treating all the other symptoms that the NHS would treat, and so is able to game the tariff system and do very well out of it, but not address the needs of the patients? Or will Any Willing Provider actually be open to these communities themselves, self-organising as groups in order to address the problems they have holistically? I think that's an open question. I think it's one of the reasons that big society matters, even in this debate around NHS reform, specifically the market mechanism. Now, we know, again, that the type of big society solutions, everything in big society is kind of peer-to-peer. It's all horizontal. It's all about how can we get people to change their behaviours. Well, we know, and every sociologist will tell you, that you change behaviour through peer-to-peer relationships. That's what drives. And if we can use this in health, you can get remarkable results. I mean, this is just smoking prevention amongst children, 20% lower, and 95% of those recruited agreed to become peer supporters. So you spread transformative behaviour and behaviour change in that manner, and there will be many other examples. Greater sense of personal and shared responsibility. And one of the things that really strikes me when you talk to doctors and is that doctors always try to treat the whole person, and yet the person then goes out to a society where they're not even recognised as a person, where they're not in society, where there's nobody they can turn to. So the doctor tries to treat them in the light of all of the connections and contexts which are so prohibitive for the patient, and yet they go back to that prohibitive context. How on earth can one help to treat that? But if we can create sort of a genuine bottom-up revolution that can start to refashion, whether you call it working class culture, culture itself, or social connection, you can actually try to produce a type of environment that gradually can become something in which patients can return to and are supported and related to and are treated as human. And there's all sorts of interesting kind of examples which I'll just click through of these sorts of enterprises or people making a difference. And of course, what's interesting to the general approach is what I'm going to show you is a series of ventures, and from a standardizing, universalizing and specialized system, it never looks enough. But actually, it's a crucial element from the bottom up that can actually make a universalized health provision really, really work. And what we need to think is we need to think about the mass micro, the way in which we can encourage all of these different forms of social and health enterprises often by the patients themselves, which together can provide the transformative context which doctors and the health service cannot provide by themselves. So these are just a few others. There's some other interesting genuine win-wins, I think. Patient hotels, which is where you build on the side of a hospital a hotel for a kind of intermediate care, where you have nurses and some emergency provision, as it were, in the reception area, but essentially you have a place that's out of hospital, but right by hospital, a kind of intermediate situation that frees up beds and actually creates a much better environment for people to get better. Scores highly in patient satisfaction, achieves the clinical outcomes at much lower costs. It is a genuine win-win, and that's the sort of situation in which I think creative thinking can really deliver. I mean, these are just examples of the good that is already out there and can be done. These are Keyring, which is in Wrexham, which is about community allotments. And it's still one of the most popular modes of application for local councils. The waiting list for allotments is vast. But what they actually do is they allow people to develop relationships in conjunction with others, and they have a support worker and carer involved. And it actually creates the networks that can deliver the health outcomes. So, and there's other things that I think we also need to talk about in the health service. It was our paper, The Ownership State, that argued for the mass mutualisation of healthcare. And that was taken up by both left and right. And it helped produce the idea that actually what we should be trying to do is to deliver healthcare via, for want of a better expression, mutualised or employee-owned companies and situations. And again, if you talk to doctors, what they talk about is we've destroyed teamwork, it's just an individual facing a lot of sick people, you can never discipline colleagues, that people sort of take time off or other doctors cover for them, and there's no proper system of remedy. And actually, so doctors are often less isolated, they're not able to control the environment around them. And so for me, a type of mutualised approach can actually restore that sense of shared responsibility and eliminate various models of free riding that clearly are prevalent and do so much to harm the morale of those who work in the health service. You all know about Central Surrey Health, so I won't go on, but it's very clear that involving staff in these new employee-owned models does everything to localise decision, reduces gaps between providers and users, increases trust, motivates, slashes cost, so on and so forth. More sort of different models of what can be done, participatory budgets. There's a whole agenda around which one can use personalised budgets, use those budgets to create and shape new models of healthcare that aren't there at the moment. If you have a personalised budget and you just approach it by yourself, it's often worse than it was before, because you have bureaucracy, you have to self-manage so much. But if you come together and can associate as a group, what you can increasingly do is create your own specialised form of healthcare, anything from leukemia to recovering from a heart attack. And that, I think, creates the situations for truly personalised healthcare through the grouping together of patients. That's something that's yet to be realised, but I think it's clearly the way to go. Social impact bonds, we've linked that with prisoner rehabilitation, social enterprises and charitable groups. The normal rate of reoffending for prisoner cohorts is about in the mid-60s. Charities can get that down to 20% or even less. Blue Sky in London gets it down to 15%, saving millions. That saving can become part of a new social investment model. But if we can do that for prisoner reoffending, is there anything we can do for health care in the same way? From smoking to obesity to depression. Is there a way of using that model within healthcare? That's something for us to discuss. So I want to sort of end now. And what I want to suggest to you is that actually the big society, it's not a necessary and sufficient condition by itself, but what it is, it's a necessary condition of delivering what you all want, which is genuine transformative healthcare in the 21st century, because it tackles potentially all of the great evils, which is the capture of political, social and economic goods by very small groups, and it seeks to give those groups to us all. Thank you very much.